Hello everyone, and welcome to the second session of clinical pharmacology and our topic about respiratory system or respiratory clinical pharmacology. In the first part, we covered the asthma clinical pharmacology, and the second part, today we are going to speak about chronic obstructive pulmonary disease, COPD clinical pharmacology. I am Dr. Hassan, Associate Professor of Clinical Pharmacology and Drug Therapy and Clinical Research. Okay, so as we already mentioned in this lecture, we have already covered the asthma pharmacology and under the umbrella of respiratory system pharmacology. We cover the asthma and we cover the treatment of asthma, the guidelines, how to treat patient, the category for asthma for intermittent, mild persistent, moderate persistent. Then we have severe persistence, and we have different approach, different treatment according to the stage of asthma. The second part of this lecture today, we are going to speak about chronic obstructive pulmonary disease pharmacology, or we call this one COPD as abbreviation. Okay, COPD as abbreviation from the chronic obstructive pulmonary disease. And we are going to speak about how to approach patients suffer from COPD. Is there any stage for COPD? So we are going to cover all of that in this lecture. Chronic obstructive pulmonary disease considered like irreversible, chronic irreversible inflammation or not fully reversible obstruction of the airflow. So what we have here, we have inflammation, we have bronchoconstriction, we have mucus, increased mucus production. So we have inflammation, we have bronchoconstriction, increased mucus secretion, and we have fibroids or fibrosis. And this fibrosis make the situation irreversible. And we have destruction of alveoli. So we have several processes may be there, and this may explain by irreversible pathophysiological changes. So we need to remember this one. COPD is a chronic irreversible or not fully reversible obstruction in the airflow, and this disease is considered like progressive disease. That means the situation may develop towards the worseness. So progressive disease characterized by persistent symptoms. Mortality, there is increase in mortality in the COPD, and the COPD considered the fourth leading cause of death in the United States. So you can see here is like very important disease linked to the mortality and morbidity. Moving to the treatment, the first things first, we go with the stop smoking cessation. Then we move to the pharmacological approach. And the pharmacological approach will be used to relieve symptoms. So we don't have a cure. We don't have a cure. Please remember that. But the treatment will be target symptoms and slow progression of the disease. Okay, we try to treat cough. We try to treat the mucus production, feeling of chest tightness, breathlessness, difficulty breathing, sleeping, and fatigue. All these will be target for the treatment. Okay, according to the article published in the journal, you can see it here is published in the journal. We have the website, we have the link for maybe credibility and for the citation and references, and they tried to find out the causes causes of COPD. So you mentioned that smoking the most important one, yes, and smoking considered like environmental factors. But we have another type of COPD could be related to the genetic COPD, and some individuals suffer from alpha-1 antitrypsin deficiency. So this is another type. This is the most common cases. This is very rare. The most common cases, cigarette smoking. The very rare cases will be alpha-1 antitrypsin deficiency. We have some case related to the childhood, related to the tuberculosis, related to the HIV, and we have some overlap between asthma and COPD. So you can see here COPD plus asthma. So we have several maybe type of COPD, but the most common one, the very common one, that will be the cigarette smoking exposure. Okay, you can see here again that from this slide they tried to show us the etiology, risk factor, tobacco use, if the person used tobacco, smoked tobacco, or we have someone in the family exposed to the tobacco. So two main causes for the COPD: using tobacco or exposed to the tobacco. Therefore, if you have someone in the family, maybe considered like smoking person, try to isolate this person in the specific room or space to avoid exposed to the smoking. Could be environmental factor like occupational dust and chemicals. Air pollution also will be related, as we mentioned, alpha-1 antitrypsin, considered like genetic, and also we have some like childhood, they suffer from poor lung growth during childhood. So all these considered like factors and etiology of. Now, how we speaking about symptoms, the patient may suffer from chronic cough, chronic sputum, dyspnea, very important symptoms there. Cough also very important, a lot of sputum and mucus. Chest tightness, we already discussed that. Risk factor, we covered that. The patients suffer from shallow breathing, increased respiratory rate. Increased respiratory rate will be increased. Here the patient will use accessory respiratory muscles. The patient suffers from cyanosis. We have the most important test used to diagnose the patient with COPD, spirometry. So spirometry, the most important one, and we go from there by diagnose the patient, and we have FEV1, then we have FVC. So we are going to discuss this function for the spirometry. Then we have radiography, arterial gases. How to diagnose patient with the spirometry? We have grade for the spirometry. We are going to speak about grade, and we have gold grade, gold 1, 2, 3, 4. So for gold 1, so you can see here the FEV1 ratio to the FVC less than 70%. This is still mild, but the diagnosis to diagnose patient with the COPD, we go with this ratio here to be less than 70. This ratio less than 0.7. Forced expiratory volume in 1 second, or in second 1, more than 80%. Here you can see here this maybe test here near normal. Therefore, could be patient may suffer from symptoms or no symptoms. Here, may need treatment or no, depends on or we can use short acting. Okay, so for the mild gold 1, the test for the FEV1 more than 80, near normal, we have symptoms or no symptoms. Moving to the moderate, we have the same for moderate. If you go look on the value for the ratio, we have the same ratio for all. So first of all, to diagnose patient, we have to look on the ratio. If the ratio less than 70, this is COPD. But is this COPD mild or moderate, severe or very severe? So we have category here. Look on the ratio less than 70, this is COPD. So now this is a case COPD. But the question, what category is this, mild or moderate, severe or very severe? This is the first step. So go with the ratio here. Go the ratio for the FEV1 on the FEC. If this is less than 0.7, this is COPD. Okay, this is the first one. Second one, we need to look on the FEV1. If the FEV1 more than 80, this is mild. FEV1 between 50 to 80, this is moderate. If the FEV1 between 30 to 50, this is severe. Less than 30, okay, above 80, this is mild. Between 50 to 80, moderate. Between 30-50, severe. Less than 30, very severe. So we have category now. Category 1, according to the, we need to diagnose the patient, COPD. Category 2, we need to look on the what type of COPD. Is mild? Is it mild or moderate? Severe, very severe. So, for example, more than 80, this is mild. Between 50, 80, this is moderate. Between 30, 50, this is severe. Less than 30, this is very severe. So this is a category for the COPD. We have two categories. First, we need to diagnose. Look on the ratio. The second one, look on the FEV1. And we have the category here to say mild, moderate, severe, or very severe. Okay. Now, as you can see from the beginning, the main cause of COPD, the main cause for COPD was tobacco. So how we can treat patients suffer from COPD and he is currently a smoking person? So number one, we have list of medication could be used for the treatment. We have bupropion and the brand name Zyban, Wolbitrin. We have nicotine. Nicotine, we have several type of pharmaceutical form. So number one, we have bupropion. Then we have number two, we have the nicotine. And number three, we have pharmacology or Chantix. So we have three group of medication: bupropion, SR, Zyban, Wolbitrin, pharmacology, and then we have nicotine. For nicotine, we have nicotine gum or nicotine lozenge, nicotine inhaler. We have nicotine nasal spray. Also, we have nicotine patches. This is very popular in clinical use. So we can use nicotine patches, nicotine gum, inhaler, or nasal spray. If you are more interested in the details and the duration of treatment, they said it should be between 8 weeks. Should be between 8 weeks to 12 weeks of treatment here to speak about the efficacy of this treatment. So it's not only for 1 week, not only for 2 weeks. We start talking about 2 to 3 months. So very important duration of treatment here. And this column mention the doses and the frequency of dose for each medication: bupropion, pharmacology, and nicotine. The duration should be around 12 weeks, but we have some cases around like 8 weeks. So in average between 8 to 12 weeks, that means around like 3 months, and sometimes we go with that 6 months. So the duration of treatment is variables, and the average will be between the 8 to 12 weeks, and sometimes we extend that to the 6 months. Okay, so you can see here the medication for pharmacology and the brand name Chantix. It's available in 2 doses, 1 milligram per tablet or 0.5 milligram per tablet. Then we have nicotine patches. Then we have nicotine nasal spray, and we have nicotine gum. So we have for the nicotine, we have this group of medication. For the pharmacology, we have tablet. For Wolbitrin, we have 2 type of brand name, Zyban, and we have the Wolbitrin. So we have Zyban here like 150. Then they said we have Wolbitrin 300 milligram. I will go back. So what type of bupropion? We are going to go the low dose, 150 milligram orally for 3 days, then twice daily. So start with 150, then escalate the dose. So start 150 milligram Wellbutrin for 3 days, then move to the 300 milligram per day. This medication bupropion decrease craving to the smoking. Also, patient here the patient need. Okay, regarding long-term oxygen therapy, they found that the use of supplemental oxygen therapy increased survivor in patient increased survivor in patients with the COPD when they suffer from hypoxemia at rest. So we prescribe the oxygen therapy. The oxygen therapy increase survivor. So increase survivor, number one. Patient receive oxygen therapy, they found a lower mortality rate. So increased survivor, lower mortality rate compared with the people not receiving oxygen. And they said when we need to prescribe oxygen to the patient, they said if the BaO2 less than 55 or SaO2 less than 88%. So we have the condition. We go measuring the blood gases, looking on the BaO2 or SaO2. If the BaO2 less than 55 millimeter mercury or Sa2 less than 88%, we start maybe medication, or we start delivering or provide supplemental oxygen therapy. Also, it's highly recommended to provide patients with vaccines, especially we talk about influenza vaccine, pneumococcal vaccine, and COVID-19 vaccines, and so on. So we have three main type of vaccine: influenza, pneumococcal vaccine, and maybe COVID-19 vaccine. It's highly recommended for those patients. Patient also recommended to go to the pulmonary rehabilitation, like exercise training. They found it's beneficial in the treatment of COPD and improve tolerance. Sometimes we refer patient to the surgery intervention. We have some condition. Pharmacological therapy is our field. They said in the pharmacological therapy, there is no medication to use to modify lung function. No medication cure what happened in the lung function, because what happened is irreversible. So what happened here, we don't have medication to modify the lung function or prolong survival. The medication mainly improve symptoms. Drug use for the COPD, we start with the bronchodilators. So for bronchodilators, now we are familiar with the bronchodilators. We go with here it's like from the name, from the name here we say chronic. So treatment will be chronic. Treatment will be long acting. Please remember that, because we have the situation long acting treatment. When you say long acting treatment, I will go with the LABA. Start with long. I will go with the LAMA. Start with long. So as you can see here, long-acting bronchodilator are preferred first-line treatment for COPD. This is a key word here. So for the chronic obstructive pulmonary disease, we go with the long-acting bronchodilator. Long-acting bronchodilator, we have two. LABA, which stand for long-acting beta antagonist, or long-acting beta agonist. Could be long-acting. We have indicatrol, oliditrol, and filantrol, and they said this group of medication prescribed once daily. Then we have salmeterol, formoterol, aformoterol twice daily. So we have indicatrol, olidatrol, filanterol once daily as a spray. Then we have another group, salmeterol, formoterol twice daily. Speaking about long-acting muscarinic antagonist, here muscarinic, we have an antagonist. Okay, we have aclidinium, tiotropium, glycopyrrolate, umeclidinium. So we have four medication. We are going to speak about which one is once daily, which one is like twice daily. Do we need to use short-acting? Okay, short-acting bronchodilator. Here we use it for patients from low risk and fewer symptoms. Okay, we can use it from time to time to relieve symptoms. Here speaking about symptoms. So we use the short-acting only for fewer symptom and low risk. So we can use it as maybe assistant therapy, short-acting. The question, can we combine LABA and LAMA together? They said yes, combination is available, also recommended for high-risk patient with more severe symptoms. So if the patient has suffered from severe symptoms, I will go with the combination treatment. Maybe use an adequate response to one agent. So I prescribe, for example, LAMA to the patient, and the patient does not respond adequately, I can combine this one with the LABA. Long-acting beta agonist or long-acting muscarinic antagonist. So you can see here we have long-acting muscarinic antagonist, LAMA. We have two groups of medication, once daily, could be once daily. We have tiotropium, we have umeclidinium, spirivia. Okay, we have spirivia here. Then we have twice daily aclidinium glycopyrrolate. So two group of medication available, once daily, group of medication prescribed once daily, tiotropium, umeclidinium, and twice daily aclidinium and glycopyrrolate. How this medication work? This medication consider like competitively inhibit muscarinic M3 receptor, and this will lead to the maybe oppose the constriction, bronchoconstriction, and try to induce relaxation of the smooth muscles. So competitively inhibit M3 receptor mediated smooth muscle constriction. And when you prescribe this medication inhaler, we avoid the systemic adverse effect of muscarinic antagonist. So for this reason, we say that we prefer to go with the inhaler more than oral or injectable, because it's less than side effect of this medication. Again, for the once daily, twice daily, we have to be familiar with the tiotropium and umeclidinium for once daily. For twice daily, we have aclidinium and glycopyrrolate, AG. Okay, do we use cortisone in the COPD? In the COPD, we use cortisone recommended in only in selected patient who's benefit from cortisone. Number one, we can add cortisone to the long-acting bronchodilator if the FEV1 less than 50. So FEV1 less than 50, we can add cortisone. Number one, glucocorticoid inhalation could be added to long-acting bronchodilator if symptom of both asthma and COPD. So if the patient come to the clinic FEV1 less than 50, and this person already on LAMA, for example, okay, this one maybe warrant to add ICS. This is number one. Number two, if the patient on the long-acting on LAMA plus persist symptoms, okay, we can add the cortisone. Okay, this is for inhaled. ICS stand for the inhaled cortisone or corticosteroid. Okay, so what about oral or systemic prescription? They said only prescribed for the patients from acute exacerbation, and we go with a short course. So if the patients are from acute exacerbation in the emergency room, we go with the oral or with the injectable corticosteroid for the short course treatment to avoid, because we have adverse drug reactions associated with the case. Okay, some studies suggest using azithromycin. Azithromycin belong to the macrolides antibiotic, and in certain pulmonary conditions such as cystic fibrosis and bronchitis, chronic therapy with a macrolide antibiotic has been proven to clinically benefit. So when your patients are from cystic fibrosis or like bronchitis, we go the uses of azithromycin. A study found that azithromycin could be 250 or 500 milligram for 12 months in patients with a COPD. They found lower the exacerbation in this patient. So the purpose there, we have specific patient will be benefit from the azithromycin, the duration of treatment 12 months, and the decreased rate or low rate of exacerbation. Okay, so from this slide here, we can use antibiotic for COPD, especially azithromycin, and you can see here azithromycin is used in specific people suffer from COPD due to the specific circumstances such as cystic fibrosis. We use azithromycin between 250 or 500 milligram 3 times per week for 12 months, and they found that this lower rate of exacerbation in patients treated with this agent. So here we have, you can see the azithromycin here, and we have the exacerbation that among selected subjects with the COPD, azithromycin taken for 1 year when added to the usual treatment decrease frequency of exacerbation, azithromycin, and improve quality of life. So you can see the situation here. Okay, decrease. So the situation here, we have proportion of free COPD. Here the patient will be free of COPD. So the azithromycin improve the exacerbation. We talk about the exacerbation here. It's like decrease the rate of exacerbation in patient with the COPD. Okay, again, this one to remind us with the what type of treatment we are going to use in patient with. If you go back to the asthma patient, the first step for treatment, short acting. So we can use albuterol, short acting as needed, BRN as needed. The first treatment on the list for long-term treatment will be inhaled cortisone low dose. If we need to escalate, medium dose of inhaled cortisone, or we add LABA. Then the second step, we go with the increased dose of cortisone, or use the medium dose, remain with using the LABA. Okay, so what we have, the purpose of this one here to show you how to escalate the dose. If you can see here, the patients suffer from asthma, we prescribe albuterol. The patients suffer from intermittent asthma, use albuterol as needed. Okay, if the patients suffer from episodes of bronchoconstriction less than 2 days per week, we use only the inhaler, short-acting inhaler as needed. Mild persistent, more than 2 days per week, not daily, we with the FEV1 normal, low dose of inhaled cortisone. Moderate persistent, patients suffer from bronchoconstriction on daily basis, function spirometry between 60-80, we start with low dose, add LABA, or escalate the dose of cortisone. Severe persistent bronchoconstrictions, the pulmonary function FEV1 less than 60, we use the medium dose cortisone, we add LABA. This is option number 1, or we increase or escalate the dose of inhaled cortisone. So as you can see here, start from for asthma, start for the SABA. The first things to add to place your patient on the inhaled cortisone. If we don't have enough response, we move to the second step, to the LABA. If it's not enough response, we move to the third step. So you can see the order for asthma: inhaled cortisone, LABA, LAMA. So I will move to the COPD to see what we have there. In the COPD, we start with the LAMA, long-acting muscarinic antagonist. If there's not enough response, we can add LABA. If it's not enough response or severe exacerbation, we move to the inhaled cortisone. So what we have here, we can type plus. So the patient with severe, we can use with COPD, severe COPD, we can use LAMA plus LABA. plus ACS. So severe exacerbation, severe case with the exacerbation. Here we use this triple therapy for the situation. How to manage the situation here, you can see we have it. If we have bronchoconstriction less than, patient come to the clinic, bronchoconstriction less than 2 days per week, we use SABA only as needed. So the patient live normal life. Less than 2 episodes, 2 days per week. Less than 2 days, 1 to 2 days per week, suffer from bronchoconstriction. And when the patient use SABA, albuterol, he will be fine. But, okay, the first medication, the patient's already in the low dose of inhaled cortisone, then we ask ourselves a question. Is the patient using SABA? So the patient now in SABA as needed plus ICS, low dose. Okay, this is a patient come to the clinic now. And we ask ourselves the question. Is the patient using SABA? Yes. Is the patient suffer from bronchoconstriction 1 to 2 per week? Does the patient use SABA 1 to 2 times per week? That's fine. Continue treatment. So continue treatment with this protocol here. If the answer no, the patient said I'm using the inhaled cortisol albuterol more than 3 times per week and sometimes daily SABA. So we remain the low dose of inhaled cortisone. We add LABA. So the second one here, if there's not enough response, to go with the medium ICS or low ICS plus LABA. Here we are speaking about asthma. Okay, if the patient on ICS and LABA and the patient using SABA and between 1 to 2 times per week, that's fine. Continue with the treatment, dual medication. But if the patient said, I'm using the albuterol SABA more than 2 to 3 times per day or daily, we need to add LABA. So you can see here we escalate the dose. Now the patient come to the clinic and he is already on medium dose cortisone plus LABA and LAMA. Okay, the patient already on three medication. And he come to the clinic for regular visit. And the patient already on medium dose, medium ICS plus LABA plus LAMA. So this is the last option here. Again, we ask ourselves the question. The patient using SABA? Yes. The patient using SABA? If we answer yes, okay, this is the first part. How many times? They said they're using SABA between 1 to 2 times per week. That's fine. Continue treatment. But this patient stated that for the previous like 1 week, 2 weeks, 3 weeks, 1 month, I don't use the SABA. So there's no zero time. No 0 time per week I use a SABA. I don't use SABA. That means the patient is now well controlled and sometimes no need to rescue inhaler. Try to drop LAMA and so on. So if the patient don't use the SABA, here what we can do, okay, we can drop one of these. We can take one of these and keep the patient onto medication. Okay. Okay, we have some category here for COPD. We need to look on the category, and this category score between 0 to 40 category score. And the first category score, as you can see, CAT assessment, A for assessment, T for test, and C for COPD. So COPD assessment test, CAT assessment, COPD assessment test. This measure the impact of the disease and the burden daily symptoms. We have some question to the patient. I never cough. I have no phlegm in my chest at all. My chest does not feel tight. So we have the question from 0 to 5. And the total score, if you answer all these 5, will be 40. And the lowest will be 0. So we can look on the data there between 0 to 40. And we are going to use this category CAT for the approach and treatment. Or category, we have A, B, C, and D. This is an old category, and now we have a new category A, B, and E, the new guidelines. So we have two approaches now according to the maybe the American Chest Association. So this is the teaching set slide. So moving to the CAT, the first one. Then we have another category. We call this one mMRC. You can see it here. Modified stand for Modified Dyspnea Scale. So we measure the dyspnea here. So we have for mMRC 0, 1, 2, 3, and 4. Okay, and the ratio here, or the score for mMRC between 0 to 4, and we are going to use it in the treatment and approach and category here. So you can see here we have 0 to 4. The question, I only get breathless with the strenuous exercise. Okay, if the patient check this one, that means that he will get 0 only. If the patient check, for example, the last one, I am too breathless to leave the house, or I am breathless when dressing or undressing, the patient will get 4. So you can see here we need to go back to this category here. So we have two categories we need to remember, CAT, and we have mMRC. Two category used for the maybe two tests we use it for the category, and we are going to speak about this category later on. And the first one will be between 0 to 40, the second one between 0 to 4. Okay, according to the new guidelines published in the 2023 in American Journal of Respiratory and Critical Care Medicine, and we have a global initiative for COPD. You can see here we have ABE, this is a new guideline, ABE, the old guidelines. The old guideline we have A, B, C, and D, and they change it to the ABE. This is a new guidelines. They look, first of all, they look on spirometry diagnosis, the confirmed diagnosis. The ratio will be less than 7 or 7%, 70%. This one for the both bronchodilators. FEV1 on the FVC less than 70. This confirms the diagnosis. The patient suffers from COPD. So the first one, the patient suffers from COPD. The second, look on the GOLD symptoms here, or the GOLD category, GOLD 1, 2, 3, 4. The GOLD more than 80, between 50, 80, 30, 50, less than 30. So depends on the GOLD here. We look on the predictive FEV1, more than 80, 50, 80, 30, 50, and less than 30. Okay, and if you remember this one, we start with the mild, if you remember, moderate, severe, and very severe. And we have it on the previous slide. Okay, moving to the exacerbation and hospital per year. So here we ask the patient question. Do you have any exacerbation? Did you go to the hospital during the last year or during the previous year? So do you have any exacerbation, or do you go to the hospital? So if the answer between 0 to 1, moderate exacerbation, 1 or less, okay, and this exacerbation not leading to the hospital, the patient didn't go to the hospital. Okay, if the patient didn't go to the hospital, in this case, during the last year, the patient will be A and B. If the patient didn't go to the hospital, A and B. If the patient states that he has more than 2 episodes of exacerbation, and this lead to the maybe going to the hospitalization or lead to the hospitalization, this consider E. Okay. Other criteria should be taken into consideration. We need to look on the CAT and mMRC. If the CAT and less than 10 and mMRC between 0 to 1, this one will be A. If the MMR and CAT more than 10 or more than 2, this one will be B. So we need to look on the data there. So does that make sense for us? So we have the category here, how we treat with the patient. Here we have case study, the patient with a long time cigarette smoker. He has a 80 back year smoking history and having smoked 2 packets since the age of 18. He has recently cut back to 1.5 because he noticed that he gets shortness of breath and moderate exertion and even at rest sometimes. So he suffered from shortness of breath at rest. Okay, this one maybe take us to the, if you remember, we have category for the symptoms coming at rest. Okay, I will go back to show you what we have. Symptoms coming at rest. Okay, and when the patient maybe it's not during walking, during rest. Okay. We look on the FEV 174 and the percentage 66. So 74, and we need to categorize the patient. He has never been to the emergency room or been hospitalized. Okay, never been. Category 13. What is his gold grade? If you remember, gold grade more than 80, this is mild. Between 50 to 80, this is moderate. So the patient will be moderate. Do you agree with this one? According to the new guidelines, ABE, what is the diagnosis of this patient? Category 13. I will move back again to that. Category 13 for the cat. He supposed to be here. Did he enter the hospital during the last year? He said no. And because his cat like 13, the patient will be here. Okay. So now, according to the guideline, which the following treatment option will be work best for this patient? So the patient will be in B, as you can see here. Okay, the patient, we have it here. So what type of treatment for this patient? Because the patient is already on B. So according to the guidelines, if the patient on the A, we go with the bronchodilator only, could be SABA or could be SAMA, like long-acting as needed, BRN. But our patient here, our patient category B. So what type of treatment? We go with the combination treatment. Okay, with the group E, if the patient suffer from history of exacerbation and leading to the hospitalization, we go with the LAMA and LABA, and sometimes we prescribe inhaled cortisone if blood eosinophil more than 300 count. Okay, the case here, patient with a post bronchodilator and the percentage FEV1, FVC 0.7 and the FEV1 69%. Patient present to the clinic and the assessment score for the CAT 12. According to the guidelines, he had never exacerbation. He had never suffered from exacerbation. According to the guideline, which of the following best stages assign as a risk factor for this patient? Is he Gold 1? Yes or no? Gold 1 should be more than 80, and this patient's not 80. Okay, if you speak about Gold 2, this patient, Gold 2, will be between 50 to 80. This is correct. This is Gold 2. Okay, risk category, there is no exacerbation. This patient is not E because we don't have exacerbation in the last year. What else? We looked on category CAT 12. This one is not A because A should be less than 10. This one could be B. It's not. We don't have C. We don't have D. So the correct answer will be, this is the correct answer. Goal 2, risk category B. Okay, so the patient here, no exacerbation. Category, this one here, and this slide here should be like this one. If you go to the slide, category Cat 12, okay, go there, and you can see here we are going with the B. Risk factor, risk category. The slide here also from the journal published, we have the link here for the citation and references. Factor to consider when initiated inhaled cortisone in patient with a COPD. So we have strong recommendation to use. First of all, we use cortisone in patient has a history of exacerbation, hospitalization, exacerbation. Here we speak about severe case. Hospitalization and exacerbation, number 1. 2, more than 2 moderate exacerbation per year. 3, we look on the blood eosinophil, more than 300 milligram cells per microliter. Number 3, he has history of concomitant asthma. That's great. So if the patient suffer from, I'll go back again. Nope. If the patient suffer from COPD plus asthma, this is indication to use ICS plus other medication. Exacerbation hospital. Here we don't prefer to use it. If the blood eosinophil less than 100, we don't use it. Blood eosinophil less than 100, we don't use it. If the patient suffers from a pneumonia event, we don't use it. If the patient suffers from infection with the mycobacterium, infections, history of mycobacterial infection, we don't use it. 3 cases we don't use inhaled cortisone. Number 1, pneumonia. Number 2, mycobacterial infection. Number 3, the eosinophil less than 100 cells per microliter. Okay, so we're done with the protocol and approaches, category CAT, mMRC with the gold 1 to 4, for example. Now we start speaking about some medication available in the practice. We are start talking about short-acting beta agonists, SABA. Short-acting beta agonist SABA, we have albuterol. We have several, maybe albuterol, levalbuterol, and we have Brover and Broventel, and that device type. We recommend to do a project about that and bring the images. Then we have short-acting anticholinergic SAMA. So we have SABA and SAMA. We have ipratropium bromide. We have it in like generic and Atrovent. Okay, so the first slide here talking about short-acting SABA and SAMA. For the long-acting, we have LABA and LAMA. For LABA long-acting beta agonist, and LAMA long-acting anticholinergic. This one is much better to say long-acting. Okay, muscarinic agent. In this case, we are going to go this 4 letter here, long-acting. This is LAMA. So long-acting muscarinic antagonist. Here we speak about LAMA. So for the long-acting LABA here, salmeterol, formoterol, orbiterol, formoterol. So we have the brand name Brovena and so on. Spirivia for tiotropium. Long-acting, we have tiotropium, aclidinium, and glucopyrrolate, and dimoclidinium, and so on. For cortisone, inhaled cortisone, beclomethasone, budesonide, we have several medication brand name in the market and the pharmacy. This is generic here. Okay, generic. Okay, fluticasone, mimetasone. So we have list of medication belong to the inhaled cortisone. We need you to be familiar with this medication. Okay, another medication available for the treatment, roflumilast tablets, and DALIRESP. Okay, DALIRESP initial USA approval 2011. How this medication work? You can see it available like tablets. Selective phosphodiesterase 4 inhibitor. Okay, DALIRESP is like selective phosphodiesterase inhibitor indicated for treatment to reduce risk of COPD exacerbation. So it's not for the regular use. If the patient suffers from exacerbations, patient with severe COPD with a acute bronchitis, exacerbation, we use roflumilast. Okay, only for the exacerbation and reduce the risk of exacerbation. Okay, most common side effect here, the adverse reaction, like more than 2% of patients are from diarrhea, weight loss, nausea, headache, back pain, insomnia, decreased appetite. If you need more information, if you click on this list here, on this link, I will click on this link for more information. Okay, so you can see here the roflumilast approved by the FDA 2011. The indication is selective phosphodiesterase 4 inhibitor indicated for the treatment to reduce COPD exacerbation in patients with severe COPD. Okay, speaking about how the roflumilast work, as you can see here in the bronchial tree, and the normal effect of cyclic AMP, cyclic AMP will be converted to the AMP adenosine monophosphate under the effect of enzyme called phosphodiesterase. So you can see here cyclic AMP metabolized by phosphodiesterase 4 into the inactive state. So for our medication here, DALIRESP roflumilast tablets, you can see here roflumilast inhibit this enzyme phosphodiesterase 4 that will lead to the increased level of cyclic AMP. This will lead to the relaxation of smooth muscles. And we have the link here for this image here. Okay, medication brand name here we try, and this one belongs to the different situation, but I was in the process to prepare like obesity booster, and this medication used for obesity. I will leave it here because not in our topics or radar. Okay, what type of medication we have for the COPD? Could be dual combination between SAMA and SABA, albuterol, ipratropium. For example, here we can use LAMA, LABA together, like phylantrol and umeclidinium. We can use dual therapy for cortisone and LABA, and mainly this one for asthma. I'll clean it first. This one mainly for COPD. And this one for quick relief symptoms. Trouble combination, inhaled cortisone, LAMA, LABA, and this one remind me with the, if you remember, stage E for the COPD, or could be severe asthma with exacerbation. We go with the three: fluticasone, umeclidinium, and phylantrol. So cortisone, umeclidinium, phylantrol. Oral medications, we have roflumilast, theophylline, and remember theophylline is not in clinical use or very rare to use due to the adverse drug reactions. Another maybe brand name, Trilogy, Ellipta, here fluticasone, umeclidinium, phylantrol, and if you click on the link here, they take you to the commercial. Then we have Ellipta, for the trilogy, 3 group of medications there. Okay, thank you everyone for your listening, and I hope in this lecture I was able to provide you with the information regarding the pharmacology of respiratory system that cover the asthma and COPD according to the instructional outcome and learning outcome and instructional objectives. We cover the asthma from several aspects. We cover the COPD also from several aspects. Thank you and have a great day, everyone.